Thank you, Ted. I'm not sure how much of the wisdom here, but hopefully I'll put together a few thoughts on the cases, which I certainly didn't give myself. But they're very real issues, and I actually, particularly this first patient, often get phone calls about similar patients. So Diane's our first patient up today. She's 56 and she's got depression, being treated with citalopram. The key issues that she's come with is that she only feels she's moderately improved, and so she's read that St John's wort is the answer and she would like to take that. She loves her morning glass of grapefruit juice. I hope she's fortunately she's not on dabigatran like the patient I saw yesterday. That's the food that patient's having with the dabigatran each morning. Has a persistent cough and somebody else has given her roxithromycin for that. Hypertension, which she's been on a thiazide diuretic for some time. And I guess, what are you going to do for her? Can you increase the dose of citalopram? And what about all her other many questions?
You're asking me?
No, I'm not asking you, Ted, but you may answer if you like. I was just going to think our way through it. So I guess my thoughts, for what they're worth around it, and we can get Ted's too, is how long has she had the citalopram for? In our instant world, we like to take a tablet and have an immediate response from it. And it's just a reminder, and you'll know far more about the practicality of giving citalopram and how well it works than I do, but it does take a wee while to start to work. It has got a good safety record in patients with heart disease, just by the by, because there's a lot of anxiety often about starting agents like that. But we all know it causes this terrible condition of a prolonged QT interval, which causes the dreaded arrhythmia of torsade de pointes. So we'll come through to that in a minute, but St John's wort first of all. St John's wort is an interesting thing. It's the kind of concept that it's natural, so it's got to be good for you. Licorice is natural, but it puts your blood pressure up. St John's wort's natural, and it does increase the serotonin levels, but it potentiates the effect of serotonin increasing medications like citalopram. And one of the problems with these agents is that you don't know how much somebody's getting. And you can't be sure that from one dose to the next it's going to be the same either. And so our patient may get more benefit if she takes St John's wort, but we don't know how much effect that's going to have on her citalopram and therefore how safe it is. So generally we'd be very keen that she didn't take St John's wort and we perhaps looked at things in another way. The long QT, we all report ECGs and we are very happy to do them, and I won't tell you how often everybody grumbles and says I've had more than my share, but that's most days. But one of the biggest requests is for the measurement of the QT. This is what is the QT, and so I don't think I've shown up a bit better. Oh dear. Exciting. Sorry about that. The QT interval is pretty easy from the Q wave to the end of the T wave. And if you've got a nice clean ECG like that, it's actually pretty easy to see where the Q begins and the T ends. It's a little bit harder when you look at the one on the left of the screen, and in fact that QT interval is prolonged. On many of the ECGs that we see, it is impossible to tell. I have to tell you where the Q starts and the T ends. So I was going to put in a few examples of what comes through, but I haven't. But the number one thing, as you can see, is you need a lovely steady baseline on the ECG. And if the baseline's wandering all over the place, you can't measure it accurately. So just number one plea is for beautiful ECGs. If you've got a lot of baseline wander, it's often from respiratory incursion, or you can have motion. Put the leads up, limb leads up on the upper chest, lower torso rather than on the limbs will make a difference. And just keeping your patients just either breathing slowly or even just briefly breath holding, but not a great big breath in, may help get a better baseline. And less tremor and movement always helps as well. So just a plea for nice ECGs. And the other practical thing from our side, if you're sending ECGs in, and yes we do, we are very happy to report them for you, is that you'll get these messages back from us that we can't report a QT on a faxed ECG. If you've ever seen an ECG when it comes in off the fax, apart from the fact there's an awful lot of grey where there were black lines, whether they're the grid on the ECG or the tracing, there's distortion, and so you cannot accurately measure an interval, and we need an accurate measure when the whole thing is distorted. So they can be scanned and emailed is often the easiest, or send in the original if you're concerned. We find the best leads for measuring the QT are leads 2 and VF. So again, look carefully at those, and is there a good quality image in those leads? And thanks to John Skinner for his work in what he calls teach the tangent, is the very simple way of doing your QT. So running a line down there straight where it intersects with the baseline, providing you've got a stable baseline, is your QT interval. And then mindful that heart rates vary so much, you measure the RR interval of the preceding QRS complexes and the square root of that, the equations on the bottom there. So it's not very difficult to do. It's good to measure in both leads, and we take the longer one rather than the average. It's tricky with atrial fibrillation, and you need to average over quite a few intervals. And these are definitions of prolonged QT, the C being corrected for the RR interval. And you note that in women, the QT interval is usually longer than in men, and different level at which we worry at. And always that grey area. People hate grey areas, but there's a grey area where it's not normal, but it's not abnormal. This is what we worry about. This is the torsade de pointe, the turning of the points on the ECG, a ventricular tachycardia that doesn't respond to antiarrhythmic agents other than magnesium, and can be brief and non-sustained like that, or can go on for long enough for your patient to collapse or at worst die. So QT interval is very important, and citalopram, as you all know, prolongs the QT interval. There are other things that can affect the QT interval with your citalopram, and grapefruit's the dreaded subject that comes up all the time. It's very fascinating, the data on grapefruit. It actually downregulates cytochrome P450 expression in the intestinal wall. And many drugs are broken down by cytochrome P450. So if you have a lot of grapefruit, there is going to be more expression of that cytochrome. It's going to, you're going to have a longer half-life if your drug's dependent on it. And in fact, interestingly, the effect can last for up to 24 hours after ingesting grapefruit. The more grapefruit you have, the more effect. And drugs do vary enormously as to how much they're affected by grapefruit. Citalopram is one that is more affected by grapefruit levels. Now, if somebody's got a normal QT interval and they want to have some marmalade or, little bit of grapefruit, it's probably not going to be a problem. But in your patient who's got a borderline high QT interval, then you're going to be worried about anything that might make that worse. The grapefruit one, just as an aside, comes up all the time with atorvastatin, and I often you go along on the side of the road, people have got out, grapefruit, please help yourself, I can't take it because of my cholesterol medication. Just, by the way, you have to have 1.2 litres of grapefruit juice to have any significant adverse effect on atorvastatin. And it's not seen with pravastatin or rosuvastatin, the interaction. So I might be a little wary if someone's on 80 of atorvastatin, but I certainly wouldn't be on 40 milligrams or less if they want to have half a grapefruit for breakfast, and certainly marmalade's highly unlikely to be an issue. So there we are. She can have a little bit of grapefruit juice if her QT's all right. Drugs that prolong the QT, just beware, they're all additive. And these are a few, there's a huge list of them, and if you ever really worried about it, if you go on the Auckland Cardiac Inherited Diseases Group website, they have a link to an excellent site that tells you all the drugs that prolong the QT. But the common ones are these SSRIs, and it's an issue throughout the whole family. The dose, the higher the dose, the greater the prolongation of the QT. The macrolide antibiotics, and this, so the erythromycin with Our Lady was a concern, or roxithromycin, and not the drug of choice. I get phoned frequently. I do a preoperative clinic in the hospital with the question of giving azithromycin as a one-off dose in women on citalopram and who've got chlamydia and the like, and a single dose is probably not going to be a problem. But if they've again got a borderline QT, you need to be careful. And interestingly, amiprazole's the other one of the list that I think is commonly used, and it does have some effect at prolonging QT. Of course, alsotalol and amiodarone are major causes. Now, any tendency of any drug to prolong the QT is potentiated by hypokalemia and hyponatremia. And if you recall back to our patient, she was on a thiazide diuretic. And there is real concern with the low potassium levels, also with low magnesium as well. So if you're starting a patient on an SSRI, I think it'd be worthwhile getting some electrolytes checked. If the potassium's normal, then I don't think it's a reason to look for another antihypertensive agent. But if they have got a tendency to a low potassium, it might be the time to look at switching that agent and go to something that's not going to adversely affect your potassium and sodium levels. So my advice to Diane was to avoid St John's wort. Just to remember that if she's only just started the citalopram, it's going to take a while to work. It's important to think about non-drug approach to also helping with her symptoms. Check the ECG, and I put there that her QT was 454 milliseconds, so it's in that horrible grey area for women. And in that case, I would be reluctant to increase the dose of citalopram. But if it was 420, I think, and she'd been on the citalopram for a while, you could look at pushing the dose up. Check her renal function and electrolytes, and unfortunately potassium was only 3.2, so we're going to replace that quickly. Magnesium's 0.6, and we're going to change it to an ACE inhibitor in the hope that we can actually maintain potassium and magnesium levels. Replace the roxithromycin with penicillin, and repeat the ECG, and with all those things, the QT corrected falls, and you need to increase the citalopram. Be very reasonable to do that, but for her, given the previous borderline QT, I would repeat the ECG a week later. And she can enjoy the grapefruit juice. Sorry, grapefruit juice is really not a big issue with citalopram, so at least you're not giving her all negative news. She can have that as well. Now, I was just going to pause for a minute on that. I've got a second case, but if there are any more issues...
I've got a few questions. Would it be in order to just pop them to you at this point?
Yes.
Well, citalopram figures here quite prominently. One question is, do we have to have an ECG before starting citalopram?
I think it's wise. It's wise, but really the rate of problems with the dose, 20 milligram dose, would be extremely low. I think your big risk comes when you're looking into the higher doses.
The other question is, Do all patients need an ECG and follow-up ECG whilst on the drug?
Again, it's easy for us. We do ECGs every day on every patient. We don't think twice about them. But it is very useful to at least know where your patient is, to know if you really want to use roxithromycin, that you've got a safety margin to do that. But doing it once, you don't need to keep repeating these unless situations change, would be my approach. And I would only repeat the ECG if the dose was increased.
The other question really is about escitalopram. Is it known to have less cardiac effects than citalopram? And which drug do you prefer, citalopram or escitalopram?
You folks know far more about that than I do. There is no, as far as I'm aware, there is no difference really in safety between escitalopram and citalopram. And in fact, they're amongst the safest of all the agents that you can give from a cardiac point of view of all the antidepressants that are available. So the other part of my message really is that it's really important to treat depression. And what we don't want is people being scared to use agents when they can be beneficial and leaving somebody with untreated depression.
No more questions.
Far on. So this time we've moved into the world of schizophrenia with Jamie. And he's been refractory to several agents, which, as I understand, is a very, very good indication for initiating clozapine, which has got amongst the best results in this group of patients. However, he's a smoker, his BMI is 36, he's gained weight recently, probably reflecting his poor mental state. His HbA1c isn't perfect, but it's probably quite good in Joey's world compared to what he might see on a daily basis. The total cholesterol's pretty reasonable, but the triglycerides are 7. So looking at that, he's got a metabolic syndrome with a low HDL, high triglycerides, diabetes, excess weight. He's got more shorter breath, and he blames the clozapine for it. What are you going to do? Well, we all worry about clozapine, and it certainly does have adverse cardiovascular effects, which can be life-threatening. And it can cause tachycardia because it's anticholinergic. It causes an orthostatic hypotension due to alpha blockade, and most feared of all, particularly in the first month of use, it can cause a myocarditis. Longer term, it can cause a cardiomyopathy, and you can see pericarditis as well. So the issue with Jamie, as I see it, is has he got a significant myocarditis, a problem which is life-threatening, for which you must stop the clozapine, or are we dealing with other completely unrelated issues that are causing his shortness of breath? And we certainly don't want to be stopping a drug which is probably our best hope in a very difficult psychiatric situation if we don't have to. Now, there's a lot of work on clozapine monitoring, and one of the very useful things in this situation would be to go back and see what he was like at baseline prior to starting the clozapine. And this is my suggestion based on various reviews put together about baseline review. Now, it'll normally be in the hands of the psychiatrist, but it's helpful just to make sure you've got this information. But do see the patient, look at them clinically, do an ECG, a chest X-ray, bloods, a full blood count. I'm not really going to discuss the hematological issues, but they're obviously important. There is some very good data on taking a baseline troponin and CRP level, so you've got something to compare to if you run into trouble. And probably also getting a baseline BNP level. BNP is really, really helpful when somebody comes in with shortness of breath, which is likely to be multiple reasons for it. Just like Jim's case with the shortness of breath and the underlying lung disease, if you've got a high BNP, there were other clinical features there where you're pretty sure it was heart failure. But if you weren't quite so sure, a BNP can be very useful. Some people recommend an echo should be done at baseline with all patients going to be given clozapine. It's not my impression that that's what's going on. Ivor would know better, he's head of our echo unit. They're certainly getting much more proactive about it. I've had lots of acute calls with trouble, but I mean, they're really, ideally they should have an echo at baseline. Yeah. And in the hospital environment they are, but if this in the community, I think it's good practice just so you know what you're dealing with. And then recommendation is for weekly follow-up. So if Jamie's come to you out of the blue and not had follow-up for a couple of weeks, then that is of concern because things do change quickly. And one of the interesting things I learnt about this is that the C-reactive protein goes up very early and troponin goes up later than that. And the C-reactive protein can go up a number of days before the troponin does if you're running in trouble with myocarditis, and that may be your first clue. The white cell counts for separate issues. So if you're concerned at all about a clinical review and an echo, and certainly an urgent cardiac review if any of those markers have become abnormal. So he's reviewed 2 weeks after starting his clozapine. He's still anxious and mildly psychotic. He's short of breath. His heart rate's 110 beats per minute. His baseline was 95, so it's gone up. He's on something that's anticholinergic. It could be doing that. He's got a postural blood pressure drop, but then we also know clozapine can do that and it can be a normal situation. However, those are both features that you might see with a myocarditis. He's got no obvious heart failure. You can't see the JVPs up, but I'd be really very impressed with anyone who thinks they can see JVPs accurately in patients of his BMI. He's got a few crackles in the base of his chest, but he's just put his last cigarette down before he walked into your room. And he's got a sinus tachycardia on his ECG. Is this helpful? Well, it's important that you do it, but I couldn't tell off that whether this was clozapine related to myocarditis or whether it's what we might expect in somebody who's still mildly psychotic and who's just started the drug. This is, so in scenario number 1 with him, you do the blood test, and he's got a C-reactive protein of 110 and a troponin I of 60. And in an Australian review, this is 100% of these patients whose C-reactive protein's over 100 and troponin I's risen by 50% from baseline will have myocarditis. So he needs to stop his clozapine immediately and be admitted to hospital. So he's easy because he's got the full house of problems. This I've just thrown in is the an Australian recommendation for following these patients, and they found the clozapine, the troponin's more than twice the upper limit of normal, or C-reactive proteins over 100 to stop the clozapine. If you've got the two together, or even that lesser rise in troponin, then you've had 100% cases of myocarditis. What we don't know is how many asymptomatic patients are being missed in this scenario. So that was kind of easy because he was so bad you had to offload him, and then you'd have to just wait till he comes out of hospital. But this is scenario 2, which is going to be the more common situation. C-reactive protein's 5, so it's slightly up, but it's certainly not going anywhere major. The troponin I is 16, so it's probably okay. And in that situation, I think you can start off by reassuring him, because you would expect by the time he's symptomatic, at least that C-reactive protein would have started to rise. But he's presented to you with a myriad of symptoms, which we mustn't forget. So don't forget your patient. And in patients with schizophrenia, the leading cause of premature death is actually coronary disease, not their mental health disease. He's diabetic, and in our world, he's not adequately controlled. Once the HbA1c is above 55, the vascular disease is going to be taking off. He's got high triglycerides, a low HDL with probable metabolic syndrome, and the obesity, which needs addressing, and clearly in that situation there's a very leading role for diet and metformin, and he's smoking, which is an enormous risk in our world. But realistically, until his refractory schizophrenia is under control, he's unlikely to be able to tackle those issues. So it's important to keep it close, to get a good rapport with him, keep in close contact, and as his mental health improves, to really work with him to try and improve those problems, which I think in this scenario are why he's got more short of breath.
Thank you very much, Fiona. And could we just... I do have... you have more questions than any other speaker. But this one is about the reliability of the calculated QTC in ECG printouts.
Well, it's almost always wrong. I think that was just another thing to pass on. The machines are reliably unreliable in all their diagnoses. I saw a patient last week acutely because of atrial fibrillation. She's a 24-year-old, completely asymptomatic. The machine had called it atrial fibrillation, and she had beautiful sinus rhythm with just a sinus arrhythmia, which is actually a sign of a very healthy 24-year-old. Equally saw somebody a couple of weeks ago with a sinus tachycardia according to the machine at 120 a minute. And you really do have to think, why is a heart rate 120 a minute? That patient had an ectopic atrial tachycardia and of course will be developing a dilated cardiomyopathy because of a rate-related cardiomyopathy. Equally, the machines just don't seem to get the QT right, and I don't quite know why, because in many ways that's something a machine should be able to do quite easily. So we really do recommend that you measure it. If anything, they over-measure the QT. In my experience, it's usually overly done.
Yeah. Time for just one more. Do you have to have regular blood tests if on clozapine, and what are they and how often?
Oh, well, I think on an earlier slide I suggested the regular tests that should be done for the first month, done weekly. The risk of myocarditis largely passes off after the first 1 to 2 months. So I don't think you need to be worrying about your BNP and your troponins and C-reactive protein, which you're using for that reason. In the longer term, the cardiac risk is a cardiomyopathy, which can occur at any time. It could be 1-2 years down the line. And really in that situation, you're only going to do blood tests based on the clinical features. If somebody starts to get short of breath or has signs of heart failure, then you might think cardiomyopathy. I'm not qualified to talk to you about the white cell count, but my understanding is that that is an ongoing risk on clozapine, and there will be some guidelines of how frequently to monitor that.
Well, with that, thank you very much, Fiona.